Good morning, ladies and gentlemen. Actually, despite we are a little bit like in the family fashion. So good morning. Actually, this is the last day of the Prague Rhythm, and the morning sessions and the live cases will be focused on the Cardioneuroablation. I think that I need to thank specifically Dan Wichterle to emancipate the system in Czech Republic, and actually the approach, and based on the passion stimulator, everything we do with Cardioneuroablation. So I would open this morning session with distinguished speakers, and actually we need to speed up because these two guys, Philippe and Dan, need to go to the lab. So please, Philippe, can you start with the first topic? And actually, do we need the other than right side for Cardioneuroablation? Is your topic right?
Yeah,
please.
That's true. May I have the slides projected? Yeah. Okay. Dear colleagues, I'm very pleased to give this presentation during this excellent conference. I would like to thank Dan and Professor Kotzner to invite me, therefore. As you know, Piotr performed the first endocardial GP ablation to treat neuromediated syncope, sinus node dysfunction, and functional AV block in 2005 and published excellent long-term results with patients with neuromediated syncope in 2011 using, it's shown on the picture, a bilateral and quite extensive ablation strategy, and the goal was to completely denervate the atria. Other groups reported positive outcomes after multi-site biatrial ablation, and Wichterle showed that targeting specific sites at the interarterial septum was particularly important to modulate the sinus node and AV node physiology. And Piotr Kulakowski will highlight later on the Warsaw approach targeting essentially two GPs. And Yao's group reported positive outcomes after multi-site LA ablation. I will later explain how we developed our approach targeting the GP through a CT-guided and right-sided approach. And Carlo successfully used an extensive right-sided approach targeting the posterior aspect of the interarterial septum. And the meta-analysis of Vandenberg showed that the results of different CNA techniques were concurrently positive. This apparent paradox between the heterogeneity of the different approaches and the concurrent positive results could be explained by a common cornerstone. And as mentioned by the author, additional data are obviously, from well-designed trials, are obviously important to assess the safety and efficacy of the different approaches. And I think that the best treatment endpoint should be associated with the lowest risk and the smallest physiological changes while able to still predict a good clinical outcome. Many publications have shown that CNA was able to elicit a sinus node and AV node vagolysis, and due to re-innervation, acute physiological changes do not equal long-term changes. And since favorable clinical outcomes have been reported with different ablation strategies, it seems important to identify a potential cornerstones of these different approaches. And the sites to be targeted could differ according to the clinical presentation as well as anatomical and procedural data. In the next slides, I will explain why and how we developed our current approach. More than 15 years ago, when performing PVI, we consistently observed a heart rate acceleration of PP interval shortening while performing RISPV ablation. We never observed this PP interval shortening while ablating the other PVs. And as this heart rate acceleration persisted after ablation, we concluded that this was not due to a stimulation mechanism, but rather to a suppression of inhibition. And where we compared the ablation site where the heart rate acceleration was observed with the known anatomy of the heart, we inferred that the structure involved corresponded to the AGP and that the AGP had an inhibiting activity on the intrinsic sinus node activity in resting conditions. And in 2014, we met a young girl who was repeatedly affected by severe paroxysmal prolonged syncope. She had a slow basal heart rate and presented an asystole of 17 seconds during the head-up tilt test. And reflex syncope had a huge impact on her quality of life and that of her parents. We were convinced that her problem resulted from an inadequate high vagal tone, and we proposed to modulate her sinus node physiology by targeting the IGP. What we did, we performed 2 sequential ablation of 1 minute with the NMAR catheter, an irrigated circular multi-electrode catheter, and we observed a shortening of the PP interval in time according to a sigmoidal curve. And after 2 minutes of ablation, I don't know if I point, after 2 minutes of ablation, the baseline PP interval shortened by 1089 milliseconds to 600 milliseconds. The basal heart rate was reset to a higher level and no residual bradycardia was observed until the discharge the following day. This can be explained by a partial suppression of the vagal inhibition of the funny current activity. And 6 months later, there was no residual bradycardia no residual heart rate activity under 50 beats per minute. And 9 years later, this patient remains completely asymptomatic and has no residual pathological bradycardia. For 9 years, the mother of this patient sent us a thank you card for Christmas and a warm email the day we performed the procedure, called by the patient her second birthday. This stress on which clinical impact this unilateral procedure targeting the IGP had for this patient. To summarize, in this patient with severe cardioinhibitory syncope, we were able to prevent syncope recurrence by creating a sinus node vagolysis to a unilateral ARGP ablation. And looking at the interaction between the right and the left heart structure, we understood that the AGP was sandwiched between the right and left atria and the surrounding ways. And to demonstrate this, we first performed a bilateral procedure in a patient suffering both from sick sinus syndrome and AF. And we intentionally first delivered a single RF application from the right side and then completed the IGP ablation from the opposite side. And we treated 4 additional patients through a right-sided approach solely. The basal heart rate was reset to a high level at 12 months after ablation compared to baseline, and there was no syncope recurrence after more than 1 year. And after this positive pilot trial, we intended to investigate the effect of cardioneuromodulation in patients with neural-mediated syncope assigned to the first group, and in patients with syncope and documented sinus pause exceeding 3 seconds assigned to the second group. I will show you here an intermediate analysis of the first 20 patients, including the trial, discuss the final results later on. The patient these 20 patients had total syncope, a total of 152 syncope. During the 6 months preceding treatment, 128 for group A, 24 for group B. And the site to target during ablation was identified offline on a CT scan, indicated by by the white line. And after a mean of 5 applications along this target line, the PP interval shortened by 219 milliseconds. And importantly, the first RF application led to a PP interval shortening of 120 milliseconds in 100% of the patients. And the high reproducibility of the data concerning the biological effect during the first ablation demonstrate the high accuracy of our anatomic strategy and that the ARGP has a precise location in humans. And after injection of 2 mg atropine, the heart rate increased by only 3 beats per minute, demonstrating that the ARGP belongs to the final common pathway of the sinus node vagal innervation. And the distance between the left and the right endocardium surrounded by the ARGP is only 3 millimeters. Hence, there is no anatomic factor potentially limiting the creation of a transmural lesion within the targeted structure to a right-sided irrigated endocardial ablation strategy. And at 6 months follow-up, syncope burden was reduced by 95% compared to baseline, and we observed a mean reduction of 99% in the heart rate time under 55 beats per minute compared to baseline. And Yao's group showed that in patients treated for AF, circumferential PVI initiated from the ARGP could effectively inhibit vagal response occurrence during the procedure. And the same group showed that among all the GPs in the left atrium, the ARGP ablation resulted in a significant increase in heart rate and suggested therefore that the ARGP is the primary target of CNA. Their approach was only left-sided, showing that an efficient ARGP ablation is feasible through a unilateral approach. And Dr. Hu previously showed the central role of the ARGP in animal studies, and also a partial modulation of the AV node is possible, can be achieved by targeting the ARGP through the ARGP pathway. ARGP pathway. This work stressed the role of the ARGP in the AV node vagal innervation. And in the Cardioneuroablation study, the final results after 1 month, there was a 95% reduction in syncope burden at 12 months versus baseline. The treatment was considered to have failed in 1 of 31 patients with neuroinhibited syncope, and in 3 patients of 19 patients with sinus node dysfunction, of which 2 were older than 70 years and hence were at higher risk of having intrinsic sinus node impairment. And the remaining 9 patients in group A, who were not free of syncope, had 93% syncope reduction, and in all of these patients, except 1, syncope recurred only after long prodromes. And importantly, in this cohort of 50 patients, none of the patients without an atrioventricular block at baseline developed a block during follow-up. Importantly as well, the patient with a mean heart rate of lower than 70 beats per minute at baseline increased their mean heart rate from 61 to 75 beats per minute at 12 months, whereas the patient with a higher heart rate at baseline than 70 beats per minute did not increase their mean heart rate significantly. And our data suggests that targeting the ARGP through a right-sided approach is enough for most patients with neuroinhibited syncope having a VASIS 1 or 2 response during tilt-table test, and for patients with functional sinus node dysfunction. For patients with functional AV block, additional ablation steps are probably important. Which additional steps? Wichterle showed that when performing an ablation at the lower part of the left atrial septum, the maximal effect in terms of AV neural conduction was reached in the perimitral position of the inferior LA. And AXU targeted different GPs sequentially and observed that in 80% of the patients with persistent AV block, a 1-to-1 conduction was achieved during ablation of the posterior medial GP. And as one of the next speakers will further detail, the RGP and the PML GP were targeted in the Roman trial by a bilateral approach using an ablation index around 45. I still have 2 slides. I show that an efficient right-sided ERGP ablation was feasible by using a very accurate and geolocalization technique and an ablation index twice as high compared to the ablation index used by the groups using a bilateral approach. Regarding the neuromodulation of the AV node, our experience is much more limited, and also we have already performed a few cases according to a bilateral approach. We recently performed an efficient neuromodulation of the AV node according to a right-sided approach. And interestingly, at the level of the IRGP, the distance between the right and the left endocardium did not exceed 3 millimeters. So in conclusion, different approaches have been associated with positive results for neuroimmunity syncope, functional sinus node dysfunction, and AV block. The RGP has been proposed as the primary target for any CNE procedure. Additional PM, LGP, or IRGP ablation is important for some patient subsets. The optimal ablation strategy is unclear, particularly for patients without clinical AV block. We have demonstrated the efficacy of a right-sided ablation strategy to target the RGP and modulate the sinus node physiology. Biophysiological knowledge and analytical data do not preclude the feasibility of a right-sided approach to modulate the AV node physiology, also no strong clinical data do exist. Optimal GP localization and energy transfer is of particular importance, even more for unilateral procedure. Additional data are important to compare the physiological changes elicited by different ablation strategies, and additional randomized clinical studies, preferentially multicentric blinded and even better double-blinded studies are important to compare the safety and efficacy of different ablation strategies for different patient conditions. Thank you for your attention.
Thank you very much. Actually, well, we are going for discussion part in the end of the session, but you will be probably in ECAM. And can we connect you in that? Okay, let's go. So, okay.
If there is any burning question, you may ask Philippe just now, because we'll be leaving after my lecture.
Actually, you know what? Let's go. Okay, so please, then the next speaker is Dan Wichterle, and he will be speaking about measurable endpoints for this cardioneuroablation procedure, and then we will discuss you two. And okay.
All right.
Perfect. Okay.
Dear colleagues, first of all, I have no disclosure related to this presentation, and my talk is focused on the need of measurable endpoints. And there are only few endpoints that are useful. And you know that these are conventional EP indices. The most specific or sensitive is results of extracardiac vagus nerve stimulation. And because only these 2 points, I add also atropine testing. You know that the atropine testing is used mainly in the phase of pre-ablation time, when we will try to assess the parasympathetic capacity or parasympathetic modulation, which reflect the subsequent effect of cardioneuroablation. But rarely it can be used intraprocedurally. And I will give some details about these advantages and disadvantages of this intraprocedural use of atropine testing. First, I will start with these very simple markers of cardiac denervation. This is important to have some baseline assessment. This is very simple EP study at the beginning of the procedure, assessing sinus node rate over a couple of cycles to be more accurate, sinus node recovery time, Wenckebach point, AVNRP. And at any time during the procedure, we may check these tests again. and assess the difference between the baseline and current state. And this histogram shows what can be achieved when you see extremely wide range of the change before and at the end of cardioneuroablation. So wide range of sinus node acceleration, shortening of sinus node recovery time, increase in Wenckebach point, or shortening of AV nodal effective refractory period. And because of this wide range, this is unlikely to be a reliable index of either sinus or AV nodal denervation. And of note, all these patients were tested using extracardiac vagal nerve stimulation, and these differences corresponds to in almost all patients, we achieved the complete denervation of sinus and AV node. Only in some of them, there were some residual responsiveness. So the same endpoint during extracardiac vagal nerve stimulation and wide responses from almost zero change in sinus or zero change in Wenckebach points, but still the patient was had denervated both sinus and AV nodes. So it is unlikely a reliable index of denervation. I will spend with a couple of words on extracardiac vagus nerve stimulation. This is the method that was published, developed and published by Dr. Pachon, and the paper appeared in 2015, and during the workshop in 2015 we demonstrated the utility of this method for the first time here, and it's based. The problem here is that you need this special dedicated neurostimulator which is able to produce these parameters of stimulation. So it means high frequency, high output stimulation with very short pulse width, and train duration is not important, but this is not possible to achieve with regular stimulator that is used during EP procedures. And the response to this stimulation, this vagal stimulation, and you see that these are the stimulation catheters introduced from the groin, from femoral veins to internal jugular vein, and we are targeting the site when the vagus nerve exits from the brain. So it is very proximal site, and it corresponds to huge vagal responses, either of sinus node when it is performed during sinus rhythm, or in the setting of atrial pacing, we may assess also responsiveness of AV node, so AV block here. And this is normal response, this is physiological response. It doesn't tell anything about if the patient is prone to syncope or not. This is physiological. But our goal is to eliminate all these responses as much as possible, of course, if it is feasible. So let's go, and I try to compare some, I put into the contrast some advantages and drawbacks of extracardiac vagus nerve stimulation. It's very simple. So I consider this highly specific and sensitive method, which is reasonably reproducible. It is quickly doable in 10 to 15 seconds. It is repeatable multiple times during the procedure. It is easy to understand and easy to quantify. Extracardiac vagus nerve stimulation offers selective assessment of SA node or AV node, as I show you on previous slide, and it gives you immediate feedback during the procedure, and you may modify your approach, or stop the procedure, or continue. There are, of course, some drawbacks, and I already mentioned some of them. You need this dedicated stimulator, and this device so far is investigational device. There is some problems with jugular vein access. There's some learning curve. Of course, some extra cost because sometimes you are not able to engage or cannulate the vein with simply plain steerable catheter. You need some sheaths, guide wires for left jugular vein, even subselectors or contrast agent. And of course, it requires some extra time for catheter positioning. You need general anesthesia with myorelaxation. because when you stimulate the very proximal trunk of the vagus nerve, there are also some motoric neurons from axillary nerve or some other, I don't know, other brain nerves. So it causes quite strong muscle cramps, which are not tolerable, and patients should be relaxated. And final 2 points. From time to time, there is a relatively weak baseline response to stimulation, and in such a case, the method is not useful. Fortunately, this is not infrequent. And sometimes the response is very sensitive to exact catheter position. And when you want to compare the baseline responsiveness and the sort of final responsiveness, you had repeatedly check the catheter position because it is extremely dependent on, but not in all patients. In some of them, it's almost not important when the catheter is positioned. Let's couple of words about why we use not only right vagus stimulation, but also left vagus stimulation. This is, we collected in the study, we collected subset of patients in whom we first stimulated right vagus only, like here, and we did our empirical procedure targeting the anterior right ganglionic plexus and posterior medial left ganglionic plexus. This one is targeted from two sides, left and right atrium, posterior septum, and this ganglionic plexus we target from 3 sides, from the bottom of left atrium, from the proximal coronary sinus and the posterior inferior part of right atrium. And we achieved complete non-responsiveness of AV node to this right vagus stimulation. And at that time, we switched for left vagus stimulation, and this histogram shows what we have observed. Of course, in maybe half of patients, there is still non-responsiveness during this stimulation, but in the other half, there is some, of course, usually not so strong as the baseline, but still a reasonable response of AV node. So it indicates that there is some differential effect between stimulation of left and right vagus, and especially, it is not important for a sinus node, but it's very important for AV node. So when you want to denervate AV node reliably, you need left vagus stimulation. Let's go back to the sinus rate acceleration. And I already talked that it is not reliable index of sinus nodal denervation, and this graph compares two indices. This is the delta sinus rhythm. This is acceleration of sinus rate during the procedure, and this max PP ratio. This is the ratio between cycle lengths achieved during extracardiac vagus nerve stimulation divided by the let's say current sinus cycle lengths. So if there is no response, this ratio should be unity 1. If the ratio is 1.5, it means that the acceleration, this is like 50% prolongation of the sinus cycle, and we consider this arbitrarily reasonable denervation. And you see that even if acceleration of and the plus minus acceleration by 20 per minute is reasonable, or by ROC analysis is optimum cutoff point for complete or incomplete denervation. And you see that in the left part of the graph, even if the acceleration of sinus rate is less than 20 per minute, you see that the maybe one third of patients have already sinus node denervated, and vice versa. Even if the acceleration is more than 20 beats per minute, there are still, let's say, 1/4 of patients who are not denervated. association with this huge or significant sinus node acceleration. So this is not reliable. Maybe it is better not to look to sinus acceleration at all, and we did this in this study. We empirically targeted the right anterior ganglionic plexus, usually with totally with 2 to 3 minutes of radio frequency, and this is what we observed. Again, in majority patients, that's 3/4, we observed total elimination of sinus node responsiveness, but there are some patients with not so strong, again, responsiveness of sinus node, but there is some response, and this is important because we know that it would be all right if there is no recovery phenomenon, but recovery phenomenon exists, and if we have patients with some residual responsiveness, they are definitely more prone to recovery in next months, and of course prone to recurrence of bradycardial symptoms. Now we go back to AV nodal denervation, and this is a study not published yet. I think it was submitted to ESC, will be presented at Amsterdam, but it's not a landmark study, so I can present it just here. We targeted the posteromedial left ganglionic plexus first without targeting the superior ganglia. And this is what we observed. We divided, there is cumulation of the effect. We consecutively targeted left atrium, coronary sinus, and right atrium. And you see that this is progressive decrease of responsiveness of AV node to extracardiac vagus nerve stimulation. And we divided the patients to 2 subgroups. In this subgroup, 11 patients, there is complete denervation of AV node. And in 8 patients, also there is still this cumulative effect of individual ablation lesion. There is no final denervation at the end of this empirical lesion. And again, this can't be assessed by any EP indices, because EP indices related to AV nodal function are even less reliable than sinus nodal denervation. So without extracardiac stimulation, you are not able to identify this subgroup of patients with non-complete AV nodal denervation. And I'm approaching to the end of my presentation. And am I late or not? Still, all right. Atropine testing using intraprocedural use. What are advantages? Atropine, again, is highly sensitive, is highly specific, it is likely reproducible, there is no study about it. It's quickly doable in 5 minutes, it's easy to understand, easy to quantify, it's cheap and generally available. But there are disadvantages. Atropine testing is not repeatable. Once you give the atropine during the procedure, you eliminate all vagal reflexes and responses, and you have no guide further. Of course, it prevents to use extracardiac vagus nerve stimulation or other surrogate indices of cardiac denervation. And so it plays a small role in guiding the procedure. It is acceptable as a final procedural step, mainly for descriptive purposes. And of course, it's less useful for assessment of AV nodal denervation, because you have to, let's say, check the Wenckebach point prior to administration and Wenckebach point after the administration and compare them. If there is improvement, AV node is not completely denervated. And I think this is not maybe last slide. What is the problem with this is not endpoint, but this is pre-procedural testing. There is problem of normality. Nobody knows what is normal response to atropine, because you may find in the literature it is acceleration more than 90 BPM or more than 25% or more than 50%, and I will give you some examples why it is nonsense. For example, this response with criterion more than 90, when there is acceleration from 80 to 95, it is like by this criterion, it is good response, but definitely like increased by 15 BPM is not. So this false positive result by this criterion. If we use this criterion of 25%, again, for example, acceleration from 50 to 65, this is 30%, but definitely this is poor response, so this is false positive result. And this is, again, this increase by 50% is, again, the previous was weak, and this is too strong. So, because the response from, let's say, acceleration from 70 to 100 is reasonable, it's less than 50%. I would consider this false negative. And even less is known about the follow-up utility of atropine testing. If you test the patient who was already ablated, and you have to decide whether to try to re-ablate, because there are no data what is normal, what is abnormal. So my summary or take-home message is this. Extracardiac vagus nerve stimulation provides the best CNA procedure endpoint, is an excellent investigational tool, is particularly useful for naive operators because of real-time feedback on CNA efficacy. Atropine testing should not be used for interim testing during CNA. It's useful for the selection of patients to the first or redo procedure, and it's useful for prediction of CNA-induced sinus acceleration. And we are just preparing study, but I will not show this just now. And finally, surrogate measures like heart rate variability, and conventional EP indices are weakly associated with the degree of cardiac denervation during CNA and unlikely reliable predictors of clinical outcome after the CNA. Thank you.
Actually, Dan, I think that it's already like 8 minutes after, you know what, so let's speed up, let's go to the lab, and actually we can take some questions later, and be ready for discussion, okay, there. Fantastic, thank you guys, okay, Philippe and Dan. And the next speaker is Michele Brignole, okay, Michele, please, okay, you are ready? Perfect. Okay, so Michele will be speaking about the pacemaker therapy or cardioneuroablation, the treatment, syncope, or actually how to define, how to select the optimal patient. Please.
Good morning. I am very happy to be here this morning and thank Joseph to have invited me, because this topic, cardioneuroablation, is a particular topic where syncope meet ablation, and syncope expert can meet ablation. Before deciding which is the optimal candidate for CNA or pacemaker, it is important to define who are the best candidate for both procedures. You know that reflex vasovagal syncope, as all reflex, the reflex arc is constituted by afferent receptors, an afferent arm, integration at the level of mid-stem cerebral nuclei, and efferent arm, and finally efferent receptors. The afferent receptor are somatic and visceral, are central, hemodynamic, mainly the baroreceptor in carotid sinus in aortic arch. The efferent arm are basically two. The sympathetic efferent arm to the splanchnic vessel and to lower limb vessel, which cause vasodilation, and the vagal efferent to the heart. Both ganglia ablation and pacemaker act at the same level, namely they counteract the vagal effect to the heart. In particular, cardioneuroablation acts in this way. The superior posteroccipital ganglion is closest ganglion to the sinoatrial node, and the inferior posteroccipital ganglion is closest ganglion to the AV node. These two ganglia, therefore, are likely to be the most important ganglia to be targeted for ablation. Both pacemaker and CNA have been proved to be effective by randomized controlled trial. 7 randomized controlled trials on pacing showed a benefit of pacing compared to control. After 1 year, the syncope recurrence decreased from an average of 40-50% in the control arm to an average of 0-20% in the active arm. And similarly, in the Roman trial, after 1 year, syncope decreased from 50% to almost 0%. Thus, pacemaker and cardioneuroablation have the same rationale, the same target. It is likely that also they show the same clinical benefit. Who are the candidates? The candidates are vasovagal syncope patient with cardio-inhibitory form. Cardio-inhibitory means almost always asystolic form. This is not enough because this patient must have severe clinical form. How to define severity? The severity is firstly defined, recognized by the patient itself, not by the physician. Patients are asking for mechanism-specific therapy because they are affected by recurrent syncopes impairing quality of life, or have syncopes with absent or very short prodrome, increasing the risk of injuries, or are at risk of syncope during high-risk activity, for example, during driving. No severe syncope, no indication, neither for CNA nor for pacemaker. I am stressing this point because you know that in vasovagal syncope there is a spontaneous high remission rate after the index visit. In this systematic review performed by the Calgary group for a total of almost 2,000 patients who had an average of 2.6 syncopes in the previous year, 35% of these patients had no recurrence during the subsequent year, with a relative risk reduction of 0.44. The proper candidates are mainly identified by tilt table testing or by implantable upper record. Both are able to identify severe asystolic syncope. Of course, both pacemaker and cardioneuroablation have extended indication in addition to asystolic syncope. But in this other indication, there is need of trials. There are no trials. And if you want to expand the indication in the next guideline of syncope, we need a randomized trial. Otherwise, the experience remains subjective. Probably, pacemaker and CNA may be effective in mixed forms and in non-syncopal extrinsic sinus node dysfunction or AV block. But as I have just said, until we do not have trials, we cannot conclude and we cannot make a clinical indication for this, remain experimental. By sure, neither pacemaker nor CNA can be used in patients with the vasodepressor form because I have shown that the target of vasodilation is not the heart. And limited to CNA, it should need perform in true intrinsic sinus node dysfunction or intrinsic AV block. This is a typical example of a good candidate. This is the trace of a implantable loop recorder. You can see that the heart rate remains stable before and after syncope. Syncope is sudden. It's preceded only by 2 or 3 beats of slowing sinus rhythm, and there is a sinus arrest of 25 seconds. This is a typical example of a good candidate identified by tilt testing. Again, you can see that the blood pressure heart rate remains stable, and only a few seconds before syncope, there is the typical vasovagal reflex of hypotension and bradycardia, followed again by a long asystolic pause. It is not unusual to observe cases that have both a positive asystolic response during tilt-table testing and the spontaneous documentation of a similar asystole during electrocardiographic recording. This is not surprising, since in the issue 3 trial, we showed that 86% of the patients who had an asystolic syncope during tilt-table testing also showed a similar asystole during implantable loop recorder. But please note, and this is a question that I would ask to Philippe Debruyne, that the contrary is not correct, because many patients with the VASIS 1, the mixed vasodepressor form of tilt-table testing, also had an asystolic event during implantable loop recorder. So, having said, who are the best candidate for this procedure? Now, when to favor CNA and when to favor pacemaker. Have a look to this graph, the age distribution of the first ever non-cardiac syncope. It's very unusual, this distribution, because it's binodal. Very rare in biology to have binodal distribution. We have a peak around the age of 20 and another peak around the age of 670. The younger population, mostly syncope is isolated. There is no associated comorbidity and justify the peak, the first peak. The older, on the contrary, are mostly associated with some dysfunction of the sinus node and of conduction property, and mostly have associated underlying disease. Looking at the distribution, it is this distribution can suggest that CNA should be preferred in the younger and the pacemaker in the older. And actually, this was the conclusion of a recent point of view of Tolga Atsu and colleague, which is going to be published to European Journal, in which the author recommends CNI first in patients less than 40 and dual chamber with closed-loop stimulation in the patient aged more than 60, leaving an individual approach in the intermediate range of 40 to 60 years. Both CNA and pacemaker have caveats. The most frequent caveats, or the most important caveat of CNA, is the limited experience in patients more than 60 years. We need trial. The need of blind randomized trial against current standard therapies. The presence of true intrinsic six-sinus syndrome and true intrinsic AV nodal disturbances, and the potential reinnervation after some time. Conversely, the caveats of pacemaker are the limited experience in patients less than 60 years, the need of replacement and malfunction increases with length of pacing, and unwillingly accepted by young patients. This is the concluding slide. Comes from a clinical controversy authored by 14 experts in syncope and ablation, which is going to be published on Europace. The summarized conclusions are intrinsic sinoatrial AV node disturbances, as well as underlying structural heart disease, but not age per se, are discriminators for CNA in the elderly. While there is no reason to restrict CNA to patients under the age of 6 who have symptoms due to vagal activation, we urgently need a controller trial to be undertaken that demonstrate non-inferiority of CNA to pacemaker implantation to relieving symptoms. Until that time, cardiac pacing is an established therapy and CNA must be considered experimental in patients older than 60 years. Let me conclude with a message of caution. The fact that the pacemaker and CNA are effective does not mean that they are always necessary in a benign syndrome such as vasovagal syncope. Thank you.
Thank you so much. Okay, and we are going to the last presentation this session. I would ask Piotr, okay, not Peter, Piotr Kulakowski from Warsaw, and he gives us the idea about the future of the cardioneuroablation, and he spent a lot of efforts to answer yes, right?
Okay, good morning. Thank you very much for inviting me to this excellent congress. So I will start with the past, but very briefly. I attended the first Prague conference in 1998, and this is a picture around 2000 with Josef, not so many gray hairs, and me with hairs. And we can also see Sebastian, who is here and in the audience. And these meetings took place at Old Ichem, and also always discussing with Josef many interesting things. Josef was our teacher in electrophysiology, and this is a picture from our first small EP lab in around 2000 when he was coming to our laboratory on Saturday and Sunday, and we performed procedures. And on the right, there is Dan Wichterle, who was teaching our doing cardioneuroablation, and Jakub Baran is here. So for many years, mainly Roman Piotrowski and me, we are performing these procedures in Warsaw. So before future current status, it was already mentioned that we have really few very good data in the literature. So there are numerous case reports and case series. There are a few studies with control group, but non-randomized and retrospective. There is only one small randomized prospective study. There are now 2 meta-analyses showing quite high efficacy, 2-year efficacy of cardioneuroablation. There will be one big report on controversies, as Michele just mentioned. So we don't have a class indication in the guidelines for cardioneuroablation yet. And just to remind this small prospective randomized study, which showed that during 2-year follow-up, 92% of patients who underwent the procedure were free of syncope recurrence, compared with almost 50% recurrence rate in control group, which was optimal non-pharmacological therapy. And as far as the quality of life is concerned, there was a significant improvement in the group which underwent the procedure, and there is no difference in the quality of life using University of Calgary scale in the control group. So there is at least this small randomized study showing that it works. So for the future, we need obviously prospective randomized trials, and I just listed a few of them which I think that should be done. So still we have only this small study comparing the procedure with optimal non-pharmacological therapy. There is no study on procedure versus spacing versus drugs. For example, in a functional AV block, the use of theophylline versus cardioneuroablation would be very interesting. There is no study of cardioneuroablation versus placebo or sham procedure. There is ongoing study in Belgium by Philippe Debruyne, but we don't know the results yet. And the problem of reinnervation, how often, to what extent, and is it good or is it bad? Everybody is saying it's bad, but in some patients it may be quite good, slight reinnervation. And also these technical things, to use or not to use extracardiac vagal stimulation, where to do this RF applications to achieve complete or incomplete vagal denervation, and do we need to do such a complicated procedure as we are doing now, or maybe simplified CNA will be good in some patients. So the first future one, and I will concentrate mainly on this, is the identification of GP, because this is the topic which is not so frequently discussed, but really we don't know where these GPs are when we are doing cardioneuroablation. This is a presumed localization of GP, not the actual in a very given patient. So because GPs are located in the epicardial fat pads, so maybe epicardial fat imaging prior to the procedure could help us to identify the correct spots in the given patient. So we have computed tomography, magnetic resonance, intracardiac echocardiography, but obviously we would like to have direct GP imaging, and currently we have MIBG which can be used for this purpose. So with epicardial fat and computed tomography, I think that there are enough data in literature showing that it is feasible. For example, in this study from Francis Machliński group, this was done before the ablation of atrial fibrillation, not cardioablation, but they wanted to identify where the epicardial fat in these patients was localized, and high-frequency stimulations was used to confirm the presumed localization of GP, and then these pictures are merged with Carter, and we can do the procedure based on this picture when we know where in a given patient are the epicardial fat paths. And also you can use in-heart, for example, as we use for VT ablation. You can do segmentation and you can send it to in-heart and get back such a very nice pictures showing where the fat pad is in a given patient. And then this may be, as we all know, incorporated in the CARTO system or other electroanatomical system. So imaging epicardial fat with CT is feasible. This may be merged with electroanatomical systems, but where exactly in this fat are GPs still we don't know. The same can be done with magnetic resonance, so I won't spend much time on this. And the third imaging modality is obviously intracardiac ice. We are doing all our procedures, not only cardioablation, but everything we are doing using ice. And this is very important because using ice, you can identify such spots as here for inferior GPs where you should burn. And if you look only at the CARTO system as here, in this patient, this area is around somewhere here. And in another patient, when you look for the same triangle, which you approach from the left atrium and then from the right atrium to burn here, is completely different. It's not here, it's here. So when you look only at the electroanatomical system, you may burn not in the place where you would like to do. So, ice imaging is feasible, shows online real anatomy and areas of presumed GP location. It is very fast creation of 3D electroanatomical map using CARTOSound. And obviously we can look at the tissue whitening and have some idea whether we burn enough or not. So, how to visualize this GP directly? So we have MIBG, and there are some small reports. First from Russia, from Novosibirsk, showing that discrete uptake areas can be identified and also incorporated in the electroanatomical image system. And there are also reports from UK showing that this is feasible. So doing CT, then SPECT with MIBG, and then transfer it to CARTO. So it is really reassuring when you are doing ablation that this is the place where this area of innervation is localized in this patient which you are doing ablation. But it is not so easy to do this. SPECT resolution is rather poor, much inferior to PET. There is no really test to confirm that this is really GP area, so high frequency stimulation is usually used. There is a need for cardiorespiratory gating, and there is a quite poor, I would say, interoperability and reproducibility of this technique, so it still needs improvement. And obviously, MIBG marks sympathetic part of GP, but we are looking for parasympathetic endings. We all think that this is a similar localization, but is it really true? We don't know. So maybe markers for parasympathetic part of GP would be better. And there is, I think, one report showing that using cholinergic radiotracer, it may be feasible. So maybe in the future, having such radiotracers will be able to track this parasympathetic endings of the nerves in the epicardial space. So to summarize this future one, so reliable and widely accessible methods for accurate localization of GPs currently do not exist but are needed. So we have pre-procedural GP imaging, merging with our system, and then to do applications. So now we are doing something like this, and I hope that within 2 or 3 years, this won't be actually the picture will be too old to show it. Now the future too, which GP and from which chamber, there were some hints on this during the previous talks. This is our experience, which will be presented at ERA meeting in Barcelona. This is just interim analysis. This is a randomized study, prospective randomized study where some patients obtain only right atrial ablation and the second group left atrial ablation. And if you look on the right atrial ablation, the extracardiac vagal stimulation confirmed the full vagal denervation only in 37% of these patients. So there were 12 crossovers, and these crossovers were mainly due to the lack of total vagal inhibition, but also due to other reasons, like 2 patients were in nodal rhythm all the time, and we didn't know where the sinus node is localized, and we didn't want to burn. And also there was some superimposition of the sinus node where we would like to burn in other 3 patients. And there were, the extracardiac vagal stimulation showed total vagal denervation in 80% of patients who underwent left atrial procedure, and the difference, this 37 versus 82, is significant. So the conclusion is, and the full data will be presented in Barcelona. So we conclude that left atrial approach is probably better than right atrial approach, and the best thing is probably to do this from both sides. So just briefly, complete versus partial vagal denervation. Pro-complete is obviously that partial vagal denervation is associated with higher recurrence rate, but let's think a little bit about partial. We don't know whether complete attenuation of vagal control is really something which is not harmful. And again, as Michele showed us, reflex syncope, at least in these young people, can resolve spontaneously. There is between 30, 40, 50 years old people, there is a decline. So maybe we can treat cardioneuroablation as a bridge to regaining normal autonomic control and not to protect from unwanted pacing. So maybe this slight reinnervation in some patients won't be so bad. The future for is this extracardiac vagal stimulation mandatory? We analyzed our patient. This is retrospective analysis. You can obtain such a nice pictures when some people have many implants. So we have this 41 patients which we performed the procedure using extracardiac vagal stimulation, and 49 in whom we did without the general anesthesia, like many people do cardioneuroablation. And there is 1 year follow-up. And syncope recurrence in this group where we used extracardiac vagal stimulation, the recurrence rate was 10%, and this simplified procedure was 14%. So there is small difference, there are small numbers. So there is the trend that the use of extracardiac vagal stimulation maybe is associated with better success rate, but maybe it is not necessary in some patients. So maybe it is not mandatory to obtain satisfactory clinical results, at least in some group of patients. So pacing was covered by Michele. I have to say that usually, obviously, we don't want to implant pacemakers in these patients, but actually pacing is not bad, and he showed that success rate with, especially with CLS, may be as high as 67–88%. Because CLS, when you think about the whole reflex, vasovagal reflex, acts actually at earlier stage than cardioneuroablation. And we have no sinus tachycardia, no inappropriate sinus tachycardia, and no POTS after pacemaker implantation. But obviously, we don't want to implant it in the young patients. There's complications. Long-term results are not known. Maybe other forms of pacing will be better. And finally, the future 6, I think that we have to talk about complications, and the complication is inappropriate sinus tachycardia. This is something which is, I think, important, because we are trying to perform total vagal inhibition. We know from old studies that elevated sinus rate may be associated with decreased survival. What if new cardiac problems occur during life and there will be no protection from the parasympathetic system if we do such a total parasympathetic denervation? So according to the literature, inappropriate sinus tachycardia can be found in 5 to 20% of patients after cardioneuroablation. So we can treat them with beta blocker together with ivabradine, but in some patients it's not enough. So how to identify preprocedurally these patients, and baseline sinus rate and response to atropine may help us, and I think that at least Dan will show us in the nearest future that it can work. So just at the end, I would like to show you very briefly this example. This is 20-year-old female with multiple syncope episodes. There are longest spontaneous asystole, not clinical, more than 3 seconds, and baseline 24-hour Holter before the procedure, mean heart rate 37 beats per minute, and very good heart rate variability. So she underwent first procedure, she improved, but syncope recurrence was present, and she opted for repeat procedure, so we did more. And after we did more, she has now tachycardia, fatigue, and this is for the more than half a year. Presyncope, mean heart rate is 107, and heart rate variability is flattened because obviously we did cardioneuroablation. And she did not respond well to beta blockers and ivabradine. So we did sinus node modification, but it was only during the procedure okay, but then again she is now in this tachycardia. So we have to do something. We have some plan to do one more procedure. So in this patient, she had very good heart rate variability, but of course slow heart rate. After these 2 procedures, she has very flat heart rate variability, and she has tachycardia. So I think this is important to show that our heart rate variability in this patient is like in diabetic neuropathy or post-MI patient with reduced ejection fraction, or in somebody with hyperthyroidism. I think we have to bear it in mind what we are doing in some patients. So in conclusion, this is obviously very promising procedure, but there are more unknowns than well-established facts. We help many people who faint, but side effects sometimes may occur. And I did not cover at all a very interesting topic, so cardioneuroablation in vagal AF, but I think it's also really very interesting territory, and they will expand in the future. So is the future bright? I think it is, but we have to be not too very optimistic. Just to quote Oprah Winfrey, when I look into the future, it is so bright, it burns my eyes. We have to be careful. So ending, I would like to invite you to our annual conference in Warsaw about cardioneuroablation. This year will be online on the 5th of September 2023. Thank you very much.
Piotr, thank you very much for the last presentation, which is like really nice end point of all the session. Actually, we are still not ready for the cases. So actually, Dan Wichterle is probably could be online for discussion. And okay, and so I will open the discussion because before the cases we are going to discuss. Can you switch off the little bit voice? Actually, can you tell them that he will be discussing?
Můžeme od začátku ten slide, prosím.
Can you just switch them for discussion, not for the case? Can you switch off the voice? Okay.
Můžeme dát první slide, prosím.
Okay, so guys, it's a very high topic. Okay, so first of all, I would stress that actually the cardioneuroablation and actually syncope management need to be clarified and need to be answered. And I feel after this, current status, we really need to get something more better, defined and put something finally on guidelines. Because this therapy, cardioneuroablation, is still not a part of guidelines. So whenever we have no guidelines, we cannot trust, the general cardiologist to refer the patients for this. And the reference of the patients is the weakest point for this, because the society, cardiology society, they clearly don't understand the issue. They finally understand, ablation or atrial fibrillation. They might understand ablation of the VT, but they don't understand cardioneuroablation. So it's our main point. So we need to be really focused. And Piotr stated very nicely that we need to simplify the method or keep it complex, but we need to do something to justify that cardioneuroablation really eliminate this patient population problem. Okay. So we would like to stress. Actually, I have a question for Michele. You stressed two important topics. And Piotr as well. Patient age. When I saw the patient from Piotr presentation with the implants, okay, it's not like 20 years old, right? He was, or he must older, okay, with implants. Is it correct? 35? 35 is implants? Okay, my God. Okay, so okay, so and the second topic Michele brought up is not just cardioinhibitory syncope, but vasodepressoric syncope. We clearly don't know how to deal with the patient and make syncopes. We don't know what to do with that. Can you a little bit stress this topic? Can you comment this, guys? Oh, okay. Perfect. No, please. Stay here, Piotr.
This is the most important point. How to define vasodepressor and mixed. Because the only way to define is to observe a spontaneous syncope and to measure heart rate and blood pressure at the time of syncope. This is impossible because at maximum we have heart rate but not blood pressure. This first. Tilt table testing. The most of the patients currently undergoing CNA, probably I suppose, have been identified by tilt table testing. Tilt table testing is very good, quite good, to identify when an asystole occurs during tilt table testing. Probably the patient have a similar asystole during spontaneous attack. But the vice versa is not correct, because many mixed forms identified by tilt table testing actually have an asystole with loop recorder. So when we say we perform CNA ablation in patients with mixed or vasodepressor form, be careful, because probably many of these may be asystolic. So if are guided by tilt table testing, I expect that we'll have a failure of ablation. If you want to increase the success rate of ablation, we need to identify the true cardioinhibitory form, because there is no rationale that CNA or pacemaker can counteract vasodepression. Vasodepression is, the heart is empty. So we cannot ablate the vagus. We have to increase blood pressure. So this is an important point for future research. What is my solution? Because is also a comment that I make to the excellent presentation, Piotr. I have learned this morning that we are unable to identify success or failure during the procedure. It is not possible. So the only possibility is to define success in the outcome and then to go back to analyze which are the parameters during procedure that can predict the clinical success. How can we define the clinical success? And then I stop. In two ways. The first is absence of recurrent syncope during a reasonable long period. Reasonable means 2-3 years, not 6 months. Secondly, implanting a loop recorder. Implant a loop recorder before ablation, documenting a systolic poses, continuing monitoring with loop recorder after ablation, documenting absence or recurrence. This is the protocol of the Italian CNA study, which is ongoing in Italy.
Piotr?
I think nothing to add.
Nothing to add?
It's obvious that the best candidate is somebody who has confirmed clinical asystole or tilt-induced asystole, and we also showed that after successful cardioablation in patients with no clinical recurrences, when you do repeated tilt tests, many of them, they will show this vasodepressor response, but they can cope with this during their everyday life. So they don't have 20-30 seconds of asystole and they don't faint. They may have some presyncopal episodes due to vasodepression, but it is much easier for them to cope with this than with sudden asystole. So.
But actually, to get, the outcome, acute outcome, I still need to stress that rather than empiric ablation, when we use in our institution the vagal stimulation, and when we really eliminate step by step, really eliminate any vagal response, like rather SI or AV blocks, so we have excellent outcomes. Okay, yes. And actually I fully agree with, put them loop recorders, but actually as a society, as a arrhythmologist, we need to really define the procedure first and then really prove, because I'm sick about to get the patient's referrals, okay? Because there are a lot of patients floating in the space and they could be referred, they are not, okay? Dan, are you online? Can we switch to Dan?
No.
He's still speaking to Dan.
Okay.
Can you focus on us?
Yeah.
Can you talk? Please don't talk to these guys. Okay. So please focus on discussion. Do you want to add something? Have you heard the discussion here?
Unfortunately, not. There was some discussion about vasodepressoric syncope, and I have no idea how to treat invasively vasodepressoric syncope. So, if there was another topic, just please repeat.
Actually, it's interesting. Actually, when we have some data about great ganglion, great splenic ganglion, actually you can access by catheter for pacing either or for ablation. So actually it is some way how to access great splenic ganglion it could be ablated, okay? So then you can get less response to keep the capacity of the vessels. So actually you can eliminate vasodilatation by that. An experiment, and it's preliminary clinical data. So it will be probably the way, but actually it's not topic of today's session, right? So actually, Dan, I have a question for you. Are you okay with empiric ablation, or you are rather still be able to get more precise data by vagus stimulation.
I would be quite happy with empirical ablation, but it is based on experience of more than 200 procedures done that were guided by extracardiac vagus nerve stimulation. So if the operator is naive, I would highly suggest to them to start with extracardiac vagus nerve stimulation to guide the procedure, to have some immediate feedback during the procedure, and when at the time of more experience, some procedures can be done, of course, without. Maybe the difference between extracardiac vagus nerve stimulation guided procedures and totally empirical ones is small, but definitely there is some, and nobody knows if it is clinically relevant or not.
But you know what? Actually, the very important aspect is how we can define the procedure to penetrate the guidelines. Okay, so we need to set up big study, and we need to unify the approach to really either like comparing sham procedure or something, but we really need to get something to get guidelines. Okay, this cardioneuroablation should be defined in the guidelines. So the approach is we need to unify our approach.
And
we need to unify the procedure.
Yeah, I think the only way how to unify is do it empirically, because this neurostimulator passion is unlikely to be certified in the near future, and this is obstacle, of course, to widespread usage of this strategy, even if it is nice and it is extremely useful for investigational purposes or for some collecting of some scientific data.
Okay.
So I think that this large-scale study should be based on a simply empirical approach. Maybe this extracardiac vagus nerve stimulation can be done in selected investigational sites, like in the background of the study, but the study itself should be done like anatomically.
Okay, Michele has a question.
Opinion.
How to reach guideline? How can CNA can reach guideline? And you suggested to have a unified methodology. This is correct. But if you look to the other procedures, AF ablation, pacemaker implantation, defibrillator, they reach guideline before having a unified methodology. So this is not the most important point. The most important point is randomized trial that show a clinical benefit. I have been asked, there has been a discussion inside the European Society of Cardiology when to write the next guideline on syncope. And the final decision was to delay guideline on syncope just to waiting for randomized trial of CNA ablation. Because if we perform the guideline on syncope in 2024 or even 2025, CNA at maximum could reach the 2B indication only for a systolic form. So it's better to wait. But I stress the expert electrophysiology to undergo randomized trial. Until that, the procedure must be considered experimental and cannot be extended to other centers except the expert that perform trials.